Dr. Pradip Jamnadas, what is it you've spent the entirety of your career, especially the last few decades of your career, focusing on?
Prevention of heart disease, which is the number one cause of death all over the world right now. You see, the heart is made up of many parts, so this is important. It's a pump, so it's a muscle. So you have diseases of the muscle. And it's rampant these days, cardiomyopathy, weakness of the muscle. Then you have the arteries on top of the heart, and that's called coronary artery disease, diseases of the arteries. They block up. Then you have the valves. The valves tend to get damaged as well. For example, aortic stenosis. And then you have the peripheral circulation, all the blood vessels that go to your carotids, your brain, your legs, and to all the organs of your body. And then you have microvascular disease, which is the tiny capillaries, that they become dysfunctional as well.
What's a capillary?
Capillary is the branch of the branch of the branch.
Okay, so like the tiny little veins.
Final ones, yeah. So when they become dysfunctional, that organ becomes dysfunctional as well. So cardiology affects all these aspects.
And how long have you been operating on people's hearts?
About 35 years now.
And how many hearts do you think you've treated?
In excess of 30,000.
And what's the age range of those patients?
They used to be mostly older people, over 65. Now, I would say 50% of them are under 65 and 50% are over 65. So the demographics is changing. The younger people are developing heart disease.
So the youngest patient you've ever treated?
28.
And what was the predicament in that case?
He was having a full-blown heart attack. So that means that one of his arteries was completely clogged up. It had a blood clot in it. There was no circulation past that artery. And therefore, he was having acute chest pain, sweating, blood pressure was low. He comes straight to the hospital. I rush to the hospital, take him straight into the cath lab and try to open up that blockage. And we did open up that blockage and we put a stent in it and got rid of that blockage immediately to restore that blood flow to the heart muscle.
And at 28, how does one get a heart attack? You said it was blocked up.
There's a lot of nuance in that. Most people don't understand what a heart attack is. So in a nutshell, I'm going to tell you what it is. When you have a plaque is a buildup of a little fibrous material inside the artery, and that doesn't cause a heart attack. A heart attack is caused when one of those plaques cracks. Now, in this diagram, for example, it's showing that the plaque is closing up the artery, and this will cause angina. That means a lack of blood supply over here. So this patient may complain of chest discomfort, or he may not complain of chest discomfort. Because remember, when you have a blockage like this, only 20% of the patients actually get chest pain. That means that you could have a blockage like this in a patient, and he may not have any chest discomfort. And the only way you're going to pick that up is by doing a stress test or a coronary calcium score or some other modality to see whether he has blockage or not. A heart attack is when a minor blockage, which is not causing much flow disturbance, suddenly cracks.
And what happens to the plaque that cracks off?
And when it cracks open, the blood that's going past it sees the crack and wants to repair it and forms a blood clot on it. So the final thing that shuts down that artery is the blood clot. It's not the plaque that shuts it off, it's a blood clot. So a heart attack is caused by a blood clot at the site of a rupture. And what causes rupture is inflammation.
Okay, so when people say that heart disease is the number one killer of people generally that are diseased, is it that process that's causing it alone, or is there a multitude of processes that lead to heart disease?
There's a multitude of things that lead to heart disease. Look.
So that was a heart attack?
That's right.
Okay.
So, one, you're making plaque. You shouldn't be making plaque. A plaque is an inflammatory area inside your arteries. It's reacting to something. And I can go into the nuance of what's the body reacting to? What's inflammation? Inflammation is reacting to something. What is that something? And I think it's important for your audience and everybody to know what that something is. Now, you got this pimple. Think of it as a pimple on the inside of the artery. Now, one day, when there's enough inflammation in your body systemically, that pimple is going to crack open, just like a pimple on the skin breaks open. Now that artery has this little pimple on the inside, and it cracks open and a blood clot forms on it, and that's a heart attack. So you don't want plaque formation, you don't want plaque instability, which is rupture of that plaque, and you don't want a blood clot to form on it. There are factors that affect each of these processes, and all three processes are going wrong today. And that's why we have so much plaque formation and instability of the plaque, which then leads, of course, to heart attacks. And our blood in general, we have more coagulation issues today than we ever did before, which means our blood, because of inflammation, is more ready to clot more easily. So we're having the perfect triad. It's the perfect storm. That's why we're seeing an epidemic of this, and that's why we're not making a dent in it. Yes, you can have a plaque rupture and have a heart attack, and we put a stent in you. Okay, that's fine. But what did we do to look at the underlying reason as to why you formed that plaque, and why did you rupture it, and why was your blood so clotty in the first place that made you actually seal off the artery?
Is this an increasing problem?
Yes, it's a huge problem because those factors have been identified now. And that's what we go for in my practice. We look for the factors. Why did you make this plaque? Why is there so much inflammation in your body? Inflammation is a reaction to something foreign. What is that foreign stuff? What is that abnormal physiology in you that your body is reacting against? Because that's what inflammation is. And inflammation, of course, whenever there's going to be inflammation, there's going to be increased tendency to make blood clots. So we go in, we chase all these things in patients to find out. And that's the real prevention.
That 28-year-old that came in and you treated him, was that a surgery you did?
We call it a surgery, but it's not. It's a angioplasty. So we go in from the wrist, or we go in from the groin with a catheter. And we go into the coronary artery.
A catheter being like a tube?
It's a hollow tube. And we put it into the coronary artery. We shoot the dye inside. We can see where the blockage is. And then we thread a tiny wire into that artery through the blockage and then bring in a balloon and squash the blood clot out of the way, restore the circulation, and then bring in a stent. A stent is like a spring that opens the artery up. We leave the stent inside there. We remove everything else. And now you have an open artery and you have blood flow going down that artery.
And what had that 28-year-old done to end up in your surgery? What were the decisions that they had made that brought them there?
So he was, number one, he was overweight. But he wasn't just overweight. The overweight was all in his belly. And he had a fatty liver. And he had what is known as visceral fat. He was not a diabetic, but he was a pre-diabetic. That means he had a lot of insulin in his body and his glucose levels were good. So if you went to his family doctor, they'll say, oh, you're not a diabetic. Your hemoglobin A1C, which is a blood test that you do for diabetes, is actually okay. But actually that patient had a very high insulin blood level. Now, insulin is a very atherogenic molecule. It causes smooth muscle proliferation. Smooth muscle is in the walls of the arteries. It causes vasoconstriction. It makes your blood more clotty. And it causes inflammation. So this patient was a pre-diabetic. And this is very important. This is what caught my attention. Because when I looked at my patients that were coming in with heart attacks and hardening of the arteries, and when I tried to identify why they're doing this, none of them were diabetics. But then I did a glucose tolerance test on them. And what happened, it was just by chance that I happened to have these tests in my office where you can measure the blood glucose. So I had about 120 of them. So I said, look, let's just do some random testing on these patients. And I found that at least half of them had no diabetes, but their glucose intolerance. That means that the sugars went up, but not enough to make them a diabetic, but it did go above the normal range. We did not have insulin testing at that time. About 10 years later, we started testing insulin in the office, and I bought a machine for this purpose in my office to measure insulin levels. And life was never the same again.
Why?
Because it's all about insulin. when it comes to the metabolic derangement. So I found that these patients, the sugars were going up to 150, 160 after giving them a glucose drink. Mm-hmm. So you say, okay, he's not a diabetic. Look, the sugar didn't really go high. But when you measured the insulin level, the insulin was off the roof.
So when you say this is an insulin problem, can you explain this to me like I have no idea what glucose and insulin are for any of my listeners out there that have a inexperienced understanding of these terms and what they do and mean?
It's crucial. Everybody needs to understand the relationship between sugar, which is glucose, and insulin. When you consume sugar or glucose, the body has to get rid of that glucose very quickly from the bloodstream because glucose actually is toxic inside the bloodstream. Even though it is what the body uses for energy, in the bloodstream, it glycates all the blood vessels and the walls and the components in blood and the hemoglobin as well, glycates it. That means the glucose attaches itself to that molecule. So now that molecule can't work properly. That is why the higher your blood glucose, all your chemicals don't work well. Your enzymes don't work well. Your hormones don't work well. Nothing works well, and you age prematurely because you're getting glycation. A glycated molecule can't work normally. It doesn't function normally. So when you consume the glucose has to come out of the bloodstream. And how does the body do it? It sends a message to the pancreas. The pancreas says, aha, I'll make some insulin. It pours insulin into the bloodstream. Insulin comes into the bloodstream, pushes the glucose into the cells. And where does it push it? Into the liver, into the muscles, into every cell in the body. Insulin will push glucose out. Now, how much insulin is the question? If I'm eating every 3 hours, and I'm consuming glucose, or I'm consuming starchy foods, or I'm consuming carbohydrates. Now watch where I'm going with this, because you're already beginning to know where I'm going with this. I'm consuming glucose and carbs every 2-3 hours. I'm stimulating my pancreas. I'm stimulating my insulin. My insulin goes up, it comes down. But before it even gets a chance to come down, it goes up again. So the repeated consumption and frequent consumption of glucose is causing my insulin to stay high because insulin stays a little bit longer in the bloodstream than the glucose. The glucose will come down in about 2 to 3 hours, but the insulin stays higher for about 4 hours. Now what happens is that you continue this lifestyle for a few years. Now the body, because these are all hormones, will say, well, I'm going to need to make more insulin now. You become insulin resistant. Any hormone that stays in your body for a long time, the body becomes immune to it. So the next time I eat the sugar, I'm going to have to make more insulin to produce the same effect. That is called insulin resistance. So now you got this patient who's been eating carbs, sugar, processed foods. What does that mean, processed foods? That means foods that are quickly absorbed into the bloodstream. Processed foods. These are products without fiber. So the absorption is very quick. So the poor pancreas has to react just like that. Produces a whole bunch of insulin. And then the frequent eating and the frequent consumption makes you insulin resistant. So now you produce a whole bunch of insulin in order to bring that sugar level down. So then you say, okay, well, it doesn't matter because the insulin is bringing the sugar level down. So what's the harm done? Because your A1C is still good, you're not diabetic. No, but it's that background high insulin that is destroying your metabolism. It's that high insulin level in the background. So insulin pushes glucose into the liver and you develop a fatty liver. It pushes the calories into production of new fats around your viscera. The viscera means in your belly, around your pancreas. You get visceral fat. Now, this fat is produced from glucose. It's a different kind of fat. Look, if I gave you a high-calorie diet right now of all sorts of foods, you put on weight everywhere, okay? But if I give you glucose, you put it on mostly in your stomach, and your stomach will protrude. And that's called visceral fat. It's on the inside. You can't pinch it. It's on the inside.
Around your organs.
Around the organs. This is very detrimental fat. And that's the epidemic that we have today.
And that's a direct result of eating, starchy, glucose, carbohydrates, which creates insulin, which creates this downstream effect on...
Wrong foods and eating too frequently.
Too frequently, okay.
Because remember, it's also the frequency of eating. Because before that insulin gets a chance to come down, you're already popping yourself with more food. And hence you develop insulin resistance. You get a very high insulin. It takes this much insulin now just to bring that sugar level down. And then the one day when you cannot control that sugar, now that sugar will go out and now your doctor will say you're a diabetic. But by that time, you've already had 10 years of hyperinsulinemia. So what happens is by the time you make a diagnosis of diabetes to say, well, now your sugar is really high. It is high because your body has not had the ability to keep it down. Why? Because even that high insulin could not keep your sugar level down. You became a diabetic. You lost that whole opportunity of prevention. It's those 10 years. Look, by the time you're a diabetic and you come and see Dr. J in his cardiac clinic, you already have coronary artery disease. Like that 28-year-old. That 28-year-old didn't have diabetes. He already has coronary artery disease. By the time you are diagnosed as having diabetes, you already have coronary artery disease. We have a great opportunity here to actually start screening these patients with insulin levels very early on. But most doctors don't have the ability or knowledge to do the insulin level testing. But it should be done.
In someone like me, I'm 33 years old now. When does the damage begin?
It starts right now. It starts right now. As soon as you're around 30, you're already starting to have trouble. You have to. But this is what I do. I look at that patient walking into my room, and if I see that he's got a belly sticking out, I already know he's probably got insulin resistance because all the fat is in here. Because the fat that's in the stomach, sideways, he looks terrible. From the back, he looks great. His waist is increased. Mm-hmm. He doesn't have all the fat everywhere else in his body. That's the phenotype of somebody who has hyperinsulinemia. That same person goes on a cruise, he'll come back 5 to 10 pounds more because he's got so much insulin in his body. Insulin is a storage molecule, puts everything away. And it's very hard for him to lose weight.
Why is it harder?
The only thing that will make you lose that fat very quickly is to change your diet, of course, but you have to do fasting. Because fasting brings your insulin level. See, this is where fasting comes in. So what does fasting do?
Do you mean fasting or a calorie deficit? Or is it the same thing in your view?
No, they're not the same thing. They are not the same thing. You see, when you don't eat, your insulin levels come down because you're not stimulating your pancreas anymore. So you want to bring your insulin levels down. The best thing you can do in the world is to do fasting. Because look, if I just simply cut down on my calories, then there's a different physiology that's going to take place in the body. And when you fast, there's a totally different physiology. When you cut down on calories, the body senses that there's caloric deficit. Your metabolic rate changes, actually slows down. And the body will start breaking down everything, muscles included. So you lose fat and you also lose muscles. On the other hand, when you're fasting, it's a different physiology. Fasting is, I've put on fat, now I'm going to take it out of the bank. Now the bank is going to be available for me to pull out my calories and use it now. And you start burning the fat. So in the first 12 hours of a fast, you take out all the glucose in the form of glycogen from your muscles and your liver. After 12 hours, you start pulling the fat out. And the first place the fat comes out of is going to be visceral fat. That is why fasting benefits you so much, because it gets rid of that worst fat, the fat that is very inflammatory. You see, if I did a biopsy of your visceral fat versus a biopsy of, let's say, a fat on your buttock, two different types of fat. One is full of inflammatory molecules. The other one is not full of inflammatory molecules. One is producing interleukin-6 and tumor necrosis factor, and this other fat is not. These are two different fat storages. Visceral fat is very toxic. It's very inflammatory. And that is why patients who have visceral fat make all these molecules. So when I do the blood test, I see that, oh, you've got so much inflammation. You've got interleukin-6 is high, tumor necrosis factor is high, your CRP is running high. And one of the reasons for this is not just leaky gut and other things that I look at, but in your case, it is also because you have a lot of ectopic fat. ectopic fat. Ectopic fat is now we're realizing is not just only around the liver and around your pancreas, it's also around your heart. So when we look at the coronary arteries and we see all those fat around the coronary arteries, you had a very nice diagram right there. And you can see that around each artery, there's that yellowness. That yellow is all plaque. Fat. There's fat around that, and it's plaque forming. It's plaque forming. It stimulates plaque. It's inflammatory. And now we can do CT scans that will actually detect how much inflammation is in the fat around the arteries as well. Ectopic fat is around the coronary arteries, it's in your liver and in your pancreas, and it is very inflammatory.
On this point of fasting, so if you have someone come to you and they have that physique where there's a bit more of that protruding belly fat, you said that fasting is a much better approach than just sort of a calorie restriction. I was looking at some studies that said research shows that calorie deficits of any kind can reduce visceral fat, but fasting will give it an edge because of the insulin sensitivity stuff that you talked about as well. What kind of fast should one be doing? Because there's so many different names for these fasts. People do these 40-day water fasts and they do intermittent fasting.
It's a great question. So there are many, many different types of fasting. Depending on your goal, on what do you want for that particular patient. So if a patient is just simply looking to reduce his visceral fat,